Hello, I'm Dr. James Whittaker, and today we're going to discuss one of the most critical decisions you'll ever make about your health after 70. If you've been diagnosed with atrial fibrillation, your doctor has probably told you that you need to take blood thinners for the rest of your life. But what if I told you that the latest medical research has completely changed the rules about who really needs these medications, and that following outdated guidelines could either put you at unnecessary risk or leave you dangerously unprotected? Just last month, a 73-year-old patient named William came to see me terrified and confused. 3 different cardiologists had given him 3 completely different recommendations about blood thinners. One said he absolutely had to take them, another said they were optional, and the third said he should avoid them entirely due to bleeding risks. William felt like he was playing Russian roulette with his health, not knowing which expert to trust. After applying the new evidence-based guidelines I'm about to share with you, William now has complete clarity about his treatment and feels confident in his decision for the first time since his AFib diagnosis. If you're over 70 with atrial fibrillation, or if you love someone who is, the information I'm about to reveal could literally be the difference between life and death. The old one-size-fits-all approach to blood thinners has been completely revolutionized by breakthrough research that most doctors haven't even heard about yet. The AFib epidemic that's silently threatening millions. First, let me paint the picture of just how massive this issue has become. Atrial fibrillation affects over 6 million Americans, and that number is expected to double by 2030. After age 70, your risk of developing AFib increases dramatically, affecting nearly 1 in 4 people by age 80. But here's what makes this so concerning. AFib dramatically increases your risk of stroke. Without proper treatment, people with AFib have a 5 times higher risk of stroke compared to those with normal heart rhythm. These aren't minor strokes either. AFib-related strokes tend to be more severe, more disabling, and more likely to be fatal. However, blood thinners come with their own serious risks, especially after age 70. Major bleeding events, including life-threatening brain hemorrhages, become increasingly common as we age. The delicate balance between preventing strokes and avoiding dangerous bleeding has puzzled doctors for decades. The revolutionary change in AFib treatment guidelines. Here's where everything has changed. The traditional approach was simple but crude. If you have AFib and you're over 65, you get blood thinners. Period. But breakthrough research has revealed that this blanket approach was causing both unnecessary deaths from bleeding and preventable strokes in people who weren't getting the right treatment. The new guidelines use a sophisticated risk assessment that considers dozens of factors specific to your individual situation. It's not just about your age and AFib diagnosis anymore. It's about your complete health picture, your bleeding risk, your stroke risk, and your personal circumstances. Let me tell you about Margaret, a 75-year-old retired nurse who was automatically prescribed warfarin when she was diagnosed with AFib 5 years ago. She's had 3 serious bleeding episodes, including 1 hospitalization for internal bleeding. Under the old guidelines, her doctors kept her on blood thinners despite these dangerous bleeding events. Using the new risk assessment tools, we determined that Margaret's stroke risk was actually quite low, while her bleeding risk was extremely high. We safely discontinued her blood thinner, and she hasn't had any bleeding episodes in over a year. Understanding your individual stroke risk profile. The key to making the right decision about blood thinners lies in accurately calculating your personal stroke risk. This goes far beyond just having AFib and being over 70. The new assessment tools consider multiple factors that dramatically influence your actual risk. Your stroke risk depends on several critical factors. Do you have a history of previous stroke or mini-stroke? Do you have diabetes? Do you have high blood pressure? Do you have heart failure? What's your kidney function like? Are you male or female? Each of these factors significantly modifies your stroke risk. For example, a 72-year-old woman with AFib, diabetes, and high blood pressure has a much higher stroke risk than a 72-year-old man with AFib but no other risk factors. The treatment recommendations for these 2 people should be completely different, even though they're the same age with the same heart rhythm disorder. Robert, a 76-year-old retired mechanic, came to see me after his cardiologist automatically prescribed apixaban for his newly diagnosed AFib. Robert was worried about bleeding risk because he's very active, does his own home repairs, and has a history of falls. When we calculated his individual stroke risk using the new tools, we discovered his annual stroke risk was only 1.2%, much lower than the bleeding risk from blood thinners given his active lifestyle and fall history. If you're serious about making the right decision about blood thinners and protecting your health, make sure you subscribe to this channel and hit that notification bell. I share cutting-edge cardiovascular health strategies every week that could literally save your life. The bleeding risk calculator that changes everything. Just as important as calculating your stroke risk is accurately assessing your bleeding risk. The old approach ignored this entirely, but the new guidelines recognize that for some people over 70, the bleeding risk from blood thinners actually exceeds the stroke risk from untreated AFib. Several factors dramatically increase your bleeding risk. Advanced age, especially over 75. History of previous bleeding episodes, kidney problems, liver disease, history of falls, alcohol use, and certain medications. If you're taking multiple medications that affect bleeding, like aspirin, NSAIDs, or steroids, your risk multiplies significantly. Here's what's revolutionary. We now have precise calculators that can tell you your exact annual bleeding risk on blood thinners versus your exact annual stroke risk without them. This allows for truly personalized decision-making based on hard data rather than general assumptions. Let me share the story of Frank, a 78-year-old with AFib who had been on warfarin for 6 years. Frank had experienced 2 serious bleeding episodes and lived in constant fear of another. His previous doctor insisted he had to stay on blood thinners because of his AFib. When Frank came to see me, we used the new bleeding risk calculator and discovered his annual major bleeding risk was 4.2%, nearly 4 times higher than his stroke risk. We safely transitioned Frank off blood thinners with careful monitoring, and he's been stable for 18 months. The game-changing new blood thinner options. Another major development is the availability of newer blood thinners that are significantly safer than the older options like warfarin. The newer medications, apixaban, rivaroxaban, dabigatran, and edoxaban, have much lower bleeding risks, especially for brain hemorrhages, which are the most feared complication. These newer medications also don't require constant blood monitoring like warfarin does. You don't need weekly blood draws, dose adjustments, or dietary restrictions. This makes them much more practical for older adults who may have difficulty with frequent medical appointments. However, these newer blood thinners aren't perfect for everyone. They're much more expensive than warfarin, they can interact with certain medications, and they may not be appropriate for people with severe kidney disease. The choice between different blood thinner options is another area where the new individualized approach makes a huge difference. Thomas, an 81-year-old with AFib and mild kidney disease, had been struggling with warfarin therapy for 3 years. His Indian rupee levels were constantly fluctuating, requiring frequent dose adjustments and blood draws. The constant monitoring was affecting his quality of life and causing tremendous anxiety. When we switched Thomas to apixaban with careful dose adjustment for his kidney function, his treatment became much simpler and his quality of life improved dramatically while maintaining excellent stroke protection. When blood thinners might not be the answer. This is perhaps the most controversial part of the new guidelines, but it's crucial information that could save your life. There are situations where the risks of blood thinners actually outweigh the benefits, even in people with AFib over 70. If your bleeding risk is very high due to factors like frequent falls, history of major bleeding, severe kidney disease, or multiple medications that affect bleeding, the safest approach might be avoiding blood thinners entirely while focusing on other stroke prevention strategies. Alternative approaches include rhythm control medications to keep your heart in normal rhythm, lifestyle modifications to reduce AFib episodes, blood pressure optimization, and in some cases, procedures like left atrial appendage closure that can reduce stroke risk without requiring blood thinners. Let me tell you about Dorothy, an 82-year-old with AFib who had fallen 6 times in the past year due to balance problems from her Parkinson's disease. Her neurologist was terrified of her being on blood thinners because any head injury could cause a catastrophic brain bleed. Using the new risk assessment, we determined that her extremely high fall risk made blood thinners more dangerous than beneficial. Instead, we focused on optimizing her blood pressure, managing her AFib with rhythm medications, and she underwent a successful left atrial appendage closure procedure. If you're over 70 with AFib, there are specific questions you need to ask your doctor to ensure you're getting care based on the latest evidence rather than outdated guidelines. First, ask for your individual stroke risk calculation using the CHA-2DS-2VASC score. This should give you a specific percentage of your annual stroke risk. Don't accept vague answers like, "You're high risk." Demand the actual numbers. Second, ask for your individual bleeding risk calculation using the HASB-LED score or similar tools. Again, you want specific percentages, not generalizations. Third, ask about the newer blood thinners and whether they might be safer for your particular situation than warfarin. Many doctors default to warfarin because it's cheap and familiar, but the newer options might be significantly safer for you. Fourth, ask about alternatives to blood thinners if your bleeding risk is very high. Many doctors aren't aware of options like left atrial appendage closure or don't refer patients for these procedures when they might be appropriate. Take a moment right now to leave a comment below telling me whether you're currently taking blood thinners for AFib and what concerns you have about your treatment. Your experience could help other viewers understand their options better. One area that's often overlooked in AFib management is how lifestyle factors can dramatically modify both your stroke risk and bleeding risk. These factors can sometimes tip the balance in favor of or against blood thinner therapy. Regular exercise, for example, can reduce your AFib episodes and improve your overall cardiovascular health, potentially lowering your stroke risk. However, if you participate in high-impact activities or have a high fall risk, this could increase your bleeding risk on blood thinners. Diet plays a crucial role as well. If you're on warfarin, foods high in vitamin K can interfere with the medication's effectiveness. Alcohol consumption increases both AFib episodes and bleeding risk. Weight management can reduce AFib burden and improve your overall cardiovascular risk profile. Sleep quality is another often ignored factor. Sleep apnea dramatically increases AFib risk and can make the condition harder to control. Treating sleep apnea can sometimes reduce AFib episodes significantly, potentially lowering stroke risk. Another breakthrough development is the availability of continuous heart rhythm monitoring that can provide much more detailed information about your AFib patterns. Traditional monitoring only captured brief snapshots, but new devices can track your heart rhythm 24/7 for months at a time. This detailed monitoring is revolutionary because not all AFib is the same. Someone who has brief, infrequent episodes of AFib has a very different stroke risk than someone who's in AFib most of the time. The new monitoring technology allows doctors to tailor treatment recommendations based on your actual AFib burden, rather than just the presence or absence of the condition. James, a 74-year-old with newly diagnosed AFib, was initially recommended for blood thinners based on his age and diagnosis. However, extended monitoring revealed that his AFib episodes were very brief and infrequent, less than 1% of the time. This low AFib burden, combined with his otherwise low stroke risk factors, led to a recommendation for careful monitoring rather than immediate blood thinner therapy. The key to modern AFib management is understanding that it's all about balancing risks. You're not trying to eliminate all risk. That's impossible. You're trying to minimize your total risk from both strokes and bleeding complications. For some people over 70, the stroke prevention benefits of blood thinners dramatically outweigh the bleeding risks, making blood thinners a clear choice. For others, the bleeding risks are so high that blood thinners cause more harm than benefit. And for a significant number of people, the risks are close enough that personal preferences and quality of life considerations become the deciding factors. This is where the new shared decision-making approach comes in. Instead of doctors making unilateral decisions based on rigid guidelines, patients and doctors work together to weigh the risks and benefits based on individual circumstances and personal values. Women face unique considerations when it comes to AFib and blood thinner decisions after 70. Women generally have higher stroke risks from AFib than men, but they also tend to have higher bleeding risks from blood thinners due to factors like smaller body size, different kidney function, and different medication metabolism. Hormonal changes after menopause can affect both AFib patterns and bleeding risks. Women are also more likely to experience certain side effects from blood thinners and may have different preferences regarding the trade-offs between stroke prevention and bleeding risk. The new guidelines specifically account for gender differences in risk calculations, leading to more accurate assessments for women. This is particularly important because women were underrepresented in many of the original AFib studies, leading to guidelines that didn't fully account for female-specific factors. Let's address the financial aspects that many people face when making blood thinner decisions. The newer, safer blood thinners can cost $300 to $400 per month, while warfarin costs about $10 per month. However, warfarin requires frequent monitoring with blood tests that can cost $30 to $50 each. When you factor in the costs of managing bleeding complications or treating strokes, the economics become more complex. A single major bleeding episode can result in hospital costs exceeding $50,000, while stroke treatment and rehabilitation can cost hundreds of thousands of dollars. Many insurance plans now cover the newer blood thinners, recognizing that their safety advantages often make them more cost-effective in the long run. However, coverage varies, and cost can be a legitimate factor in treatment decisions for people with limited financial resources. The future of AFib management. Exciting developments are on the horizon that will further revolutionize AFib management. New medications with even better safety profiles are in development. Improved risk prediction tools using artificial intelligence are being tested. Novel procedures for stroke prevention without blood thinners are showing promising results. Genetic testing may soon help predict who will respond best to different blood thinners and who has higher bleeding risks. Continuous glucose monitoring style devices for heart rhythm tracking are becoming available, allowing for unprecedented insight into AFib patterns. These advances mean that the landscape of AFib management will continue evolving rapidly. What's most important is ensuring that you're working with healthcare providers who stay current with the latest developments and who take an individualized approach to your care. Here's exactly what you need to do if you're over 70 with AFib to ensure you're getting the best possible care based on the latest evidence. First, request a comprehensive risk assessment that calculates both your stroke risk and bleeding risk using validated scoring systems. Don't accept treatment recommendations based solely on your age and AFib diagnosis. Second, discuss all available blood thinner options with your doctor, including the newer medications that may be safer than warfarin. Understand the pros and cons of each option for your specific situation. Third, consider extended heart rhythm monitoring to better understand your AFib patterns and burden. This information can significantly impact treatment recommendations. Fourth, review all your medications with your doctor to identify any that might increase bleeding risk unnecessarily. Sometimes simple medication adjustments can significantly improve the risk-benefit balance of blood thinners. Fifth, optimize your lifestyle factors that can reduce both AFib episodes and stroke risk. This includes blood pressure management, weight control, exercise, sleep optimization, and alcohol moderation. As we wrap up today's discussion, I want to emphasize that there's no single right answer for everyone over 70 with AFib. The right decision for you depends on your individual risk factors, your personal values, your quality of life considerations, and your specific circumstances. What's changed dramatically is that we now have the tools to make these decisions based on precise, individualized risk calculations rather than broad generalizations. We can tell you with remarkable accuracy what your specific risks are with and without blood thinner therapy. Remember William's story from the beginning? He was confused by conflicting recommendations from different doctors because they were using different approaches, some using old guidelines, others considering only certain risk factors. Once we applied the comprehensive new risk assessment tools, the right decision for William became clear, and he gained the confidence he needed to move forward with his treatment. The key is finding a healthcare provider who understands the new evidence-based approach to AFib management and who will take the time to do a thorough, individualized assessment of your situation. Whether you decide to take blood thinners or not, the most important thing is that your decision is based on accurate information about your specific risks and circumstances. The days of one-size-fits-all AFib management are over, and that's great news for patients who want truly personalized care. If you found this information helpful, please share it with others who might be facing similar decisions. Too many people over 70 are still receiving AFib care based on outdated guidelines, and spreading awareness of these new approaches could literally save lives. Thank you for watching, and remember, you have the right to expect individualized, evidence-based care for your AFib management. Don't accept generic recommendations when personalized assessments are available. I'll see you in the next video, where we'll explore more cutting-edge strategies for cardiovascular health after 70.